I'd like to welcome everybody to today's presentation on long-term impacts of adverse childhood experiences and trauma. I'm your host, Dr. Dawn-Elise Snipes. Childhood trauma and ACEs fundamentally alter each piece of a child's life. And we're going to go through those today and explore how those alterations in each piece of a child's life can contribute to mental as well as physical illness and other problems later in life, as well as strategies we can use to assist people in recovering and healing from these traumas. We're going to explore the relationship between ACEs, that's adverse childhood experiences, trauma, and attachment trauma. We'll identify the impact of ACEs and traumatic injury on all pieces of life, and explore risk factors for ACEs and subsequent prevention and intervention measures. Let's start out at the beginning, the very basics. What is trauma? And I use a few different nuances. Traumatic events are things that happen that directly or indirectly expose a person to something that involves the possibility of death or serious injury. In children, this can include, in my opinion, attachment trauma, since, loss of a caregiver is really tantamount to death or serious injury. A 5-year-old cannot care for themselves. Being in a household where there is almost never food in the refrigerator, where they're hungry all the time, that neglect makes the child feel unsafe, makes the child feel anxious, and potentially, if they're not fed for long enough, it could lead to serious injury. Attachment trauma is a specific type of trauma. When somebody experiences attachment trauma, their primary caregivers did not demonstrate the characteristics necessary to form secure attachment. They did not demonstrate consistency, attentiveness, responsiveness, encouragement, and safety. And traumatic injury, and I think this is really important because a lot of people, almost everybody, I think, experiences trauma in their life. Not everybody experiences traumatic injury. And traumatic injury are the psychological consequences, sometimes experienced after a trauma, causing the person to feel unsafe and powerless. And when traumatic injury is left unresolved, like any other injury we get that's left unresolved, it may heal incorrectly, if you will. Like if you get a bone broken and you don't get it set, it may heal a little not correctly. Or it may just kind of stay open and fester. And that's really what we're talking about today. We're talking about childhood experiences that were traumatic to the child that were never healed or didn't heal appropriately. Adverse childhood experiences are stressful or traumatic events that children experience before 18 years of age. Studies have linked exposure to ACEs and negative health and developmental and behavioral outcomes. 18 years of age, it is so arbitrary. They have that cutoff for adult versus child. But when we really think about it, our brain is still developing into our early to mid-20s. And we want to recognize that when our brain is still doing that development, it is more malleable. It is like a clay pot that has not yet been put into the kiln. And it's much easier to poke holes in it or to dent it or cause it to become misshapen in some way. Once it goes into the kiln, you can tap on it and it's not going to alter much. 61% of adults surveyed across 25 states reported that they had experienced at least one type of adverse childhood experience. And you'll see in a minute, this very easy to do. And nearly 1 in 6 reported that they'd experienced 4 or more types of adverse childhood experiences. They found that the greater the number of ACEs that somebody experiences, the worse their prognosis is for mental health and physical health later in life. Well, let's think about it. The more traumas a person experiences, the more stress they undergo, the more unsafe they may feel, the more inflammation they may develop, and then we have the cascade of consequences. What are these adverse childhood experiences? And the ACEs Too High study lists them sort of more individually. I've grouped them into 3 general categories. Abandonment is the first category. Death of a parent. And we know that death of a parent is traumatic, especially if it's due to suicide. Divorce. When parents get divorced, it can be an amicable divorce and the child may deal with it well, but a lot of children, even in amicable divorces, experience some level of distress. Not all children. Sometimes the divorce is a relief to the child because it's like, oh my gosh, we're not having screaming all the time anymore. This is wonderful. Or if a caregiver or someone in the household goes to jail. Remembering with children, their household impacts their very being, not just their primary caregiver. But if they're in a household where there is chaos, where someone commits suicide, where someone has a mental illness, it creates an environment that is different than someone who is in a household that doesn't have those experiences. The second category is abuse or neglect, either experiencing it directly or witnessing it, as in the case of witnessing domestic violence, or experiencing abuse or bullying by a sibling, or obviously caregivers. But this abuse or neglect can occur in any piece of life. It doesn't have to be physical. It can be interpersonal, where the relationship is abusive. It can be emotional abuse. It can be mental abuse. We need to recognize, and I have environmental abuse that can kind of go under emotional too. If the abuser is invading that person's space, invading that person's stuff, or maybe even taking it, getting rid of their dog, for example, that can be traumatic. And mental illness or substance abuse or other addictions, behavioral addictions included, gambling, sex, porn, in the household. What happens when there's chaos in the household? I want you to think about the family dynamics. We'll just take the Beaver Cleaver household of mom, dad, and 2.4 kids and a dog. But if one of them starts to develop a mental illness, a substance abuse issue, become neglectful, etc., it affects every other person in that household. And that may mean that the child who's experiencing the trauma may not be getting the attention that they need because the caregivers are focused on the sibling that has the mental health diagnosis or the addiction issue. It may be cause the parents, the caregivers, to focus on themselves because they have a conflictual relationship and the kids just kind of fall to the background. So they're not getting their needs met. It may not be overt abuse, but it may be neglect. The children aren't getting their emotional needs met. They're not feeling safe. They're not feeling supported. They're not feeling noticed. So let's think about how these issues impact the child. Abandonment. If there's a death, and it can be due to illness, suicide is definitely more impactful because the child often feels responsible in some way. Or if the caregiver goes to jail, or if there's a divorce. A lot of times, children after a divorce are worried that they're going to be kicked out of the house too if they don't do right, or they may blame themselves for the divorce. There's a lot of things that can go on in a kid's head because remember, kids don't think the same as adults. Young kids especially, they think personally. What happened was my fault. I did it somehow. It's I did something. They have a lot of magical thinking and tend to think they have a lot more power than they really do. They think egocentrically. Their perception, if they think this is what happened and this is why it happened, they think everybody else thinks that. So if they think it's their fault, they truly believe that everybody else knows it's their fault. They think in all or nothing terms. You love me, you hate me. You're safe, you're unsafe. I'm safe, I'm unsafe. Therefore, a child who is thinking in those concrete, dichotomous, personalized, egocentric terms may very quickly feel unsafe if a caregiver passes away. They're like, what's going to happen? Who's going to feed me? Who's going to make sure I get medical care? A lot of times, if there's a divorce or a death or somebody leaves the household because they're incarcerated or something, it changes the rhythm of the household. So the child's circadian rhythms may get, kind of tossed up in the air for a while because they're having to adjust to a new schedule, a new routine, a new normal without that other person in the household. And they may feel more or less physically safe, depending on the characteristics of the caregiver that abandoned them. And as a child, a lot of children perceive it as abandonment in some way, even if the caregiver didn't have any control over it. Thinking about through a child's eyes, with this person not in the house, do they feel more or less safe? Do they feel more or less confident that they're going to get their food needs met, their medical needs met? They're going to have a roof over their head. What's going on with them? So it impacts the child a lot. When there's abuse or neglect, that's pretty obvious that the child is fearing for their food, medical, or physical safety, which is going to keep them from getting good quality sleep. Even if they're not the ones that are bearing the brunt of the abuse or the neglect, they're worried, they're fearful, maybe for other people in their household, or even neglect as no food in the house. It's hard to sleep when you're really hungry. It's hard to sleep when you don't know who's coming in and out of the house. And then mental illness or substance abuse. When we have that going on in the family, what we see is a lot of chaos often. And the person with the mental illness or the substance abuse often becomes the focal point of the family, if you will, trying to help them get better, trying to help them survive, trying to help them avoid the natural consequences of their behaviors and other enabling things that happen. But that draws the attention toward that person and away from the child. So the child doesn't feel noticed, doesn't feel like they're getting their needs met. They may not, because the adults are so focused on the person with the mental illness or addiction, a lot of what the child needs may go unmet because the caregivers just don't notice, or they don't have the bandwidth to handle one more thing. It's like, okay, you're having a bad day. I'm sorry, but your brother's having a worse day. So deal with it. Interpersonally, and again, all of these go to basic safety and needs, love and belonging, learning how to set boundaries and communicate, developing self-esteem and trust. When there's abandonment in the household, and I'm just using that term generally now, we're not going to go through each one. A lot of times the child doesn't know who to trust because all of a sudden this person who was there is gone. How can I trust that that's not going to happen again? They may feel guilty or may feel they brought it on themselves. That causes problems with self-esteem. They may not have a caregiver who's able to form that secure attachment and be responsive to them. So they may not learn how to set boundaries and communicate effectively. When there's abuse or neglect, same thing is going on. And, you can kind of see the theme here. When the child feels unsafe for some reason, it's going to impact them. Emotionally, they experience a lot of dysphoric emotions. They may not have the bandwidth to experience happiness. They may feel guilty for feeling happy. They may just not feel happy. Children aren't born knowing how to identify feelings, so they may not develop a good emotional quotient or emotional intelligence. They can't differentiate how they're feeling. They go from feeling flat or blah or to enraged or terrified or depressed. And that's about all that they can identify. And when we don't have good emotional identification and emotional awareness, it's really hard to manage our emotions if we don't feel it coming up, if we're on autopilot, and if we don't have somebody teach us how to downregulate and manage our emotions. We're not born with that. Then the child is going to be more prone to experiencing distress, fearing their emotions are going to overwhelm them, experiencing dysregulation because they're stressed out. And that constant stress alters the nervous system, and the child is going to be more prone to dysregulation. Likewise, when we're stressed, when we're more prone to dysregulation, our wise mind, our prefrontal cortex, kind of shuts off. The blood sugar is shunted away to help us fight or flee. All of those executive functioning things that we talk about, planning, organizing, remembering, attending, concentrating, those are out the window. Those are out the window because that child, because they feel unsafe and they're not getting their needs met, is focused on survival. They're not focused on algebra. It also alters their perceptions. When you're living in an environment that is hostile, negative, unsafe, that's what you start to expect from the world. You expect people to be hostile, unpredictable, unsafe. Therefore, they're viewing their interactions with other people through that lens, expecting the worst instead of believing or recognizing that, hey, what I'm going through is not the norm and other people can be trusted. Environmentally, housing, transportation, that's left up to the caregivers. And if the caregivers are too overwhelmed dealing with their stuff or dealing with the stuff of somebody else in the household, then housing may become unstable. They may lose their jobs. They may get DUIs. There may be transportation issues. They may lose the car. It's very easy for some of our fundamental basic needs, if you think back to Maslow's hierarchy, to go by the wayside when someone is having difficulty functioning, when the grown-ups in the household are having difficulty functioning. To this point, we've talked about how adverse childhood experiences may impact the child. Overall, increases stress, increases inflammation, decreases sleep, decreases nutrient absorption, decreases mood, decreases executive functioning. There's a lot of distress that we see. And until the child feels safe and empowered, it's going to be hard for them to sort of get stabilized and develop a lot of those skills. Some of the first things that we can do is help the child feel safe and empowered, help them get into an environment. And a lot of this results when we start working with the adults in the household to help them make sure the child feels safe and supported. The caregivers, when there's a suicide in the family, the caregivers are going to be overwhelmed. They are going to be distraught. When there's a divorce, the caregivers are distraught. When somebody goes to jail, whether it's the partner or a child, a lot of times the caregivers are angry, distraught, overwhelmed. When there's abuse or neglect in the family, whether they're the brunt of it or they're the perpetrator of it, they're not focusing on what the child's needs are. They are feeling, and if they are being victimized or they're trying to prevent somebody else from being victimized, maybe a sibling is being bullied at school, that may take all of that caregiver's attention. Therefore, the caregiver may not be sleeping well. If they're experiencing the abuse or neglect themselves, they may not feel safe. Interpersonally, they may have difficulty trusting the people in their own household. They may not feel good about themselves or efficacious because they're not being the caregiver that they think they should be, or they blame themselves for what's going on in the house. When this starts happening, you can see how caregivers can get up in their own head and have difficulty getting out and focusing on the child. Emotionally, when any of these things are going on in the household, it's exhausting. It can be terrifying. It can be gut-wrenching, heart-wrenching. There's a lot of dysphoria in the household, and the caregivers may get to the point where they've been so stressed for so long that they too start dysregulating, going from flat to furious or flat to frantic. Cognitively, same thing happens in adults that happens in kids. When we get stressed and that stress response is on, our executive functioning, not so much. And it's not either completely on or completely off. It's all a matter of degrees. But the more stressed someone is, the more difficult it is to think clearly. The more difficult it is to perceive the world through a clear lens, as opposed to a lens that is colored by distress, by fear, by a sense of unsafeness. So the caregivers are starting to feel overwhelmed, unsafe, powerless. We know that kids, even if they don't say a word, we know that kids pick up on this. So kids start to pick up, hey, my caregiver doesn't even feel safe. My caregiver can't even handle this. If they can't handle it, I'm screwed. Quite honestly, that's what a kid's thinking. And as a result of the caregiver being completely verklempt and the child feeling scared and distressed, and often when that happens with children, we see one of two things. They either withdraw or they act out because they're either trying to avoid the wrath or avoid whatever, or they are trying to get some boundaries, get somebody to notice. It's like, hey, I'm over here. Negative attention's better than no attention. Do you notice me? We start to see a lot of behavioral issues in children. We also start to see a lot of symptomatology of ADHD. And I think it's really important as clinicians that we examine executive functioning deficits through the lens of when did it start, what's causing it, and what helps them manage it. Is there a history of trauma? Is this person having difficulty focusing and planning and organizing because they're constantly in fight or flight? Over 50% of adolescents have been exposed to ACEs, which can have detrimental effects on physical health, learning, and behavior, and is associated with increased suicidal ideation. Because exposure to ACEs, especially multiple ACEs, can leave a child feeling helpless and hopeless. 68.1% of people who reported homelessness in childhood also reported experiencing 4 or more adverse childhood experiences. Go figure. Generally, people who become homeless have experienced, the caregivers are experiencing mental illness or addiction, or there's been some sort of violence that they were trying to flee from. There can be a sense of abandonment, because if there's interpersonal violence, that's the abuse. And if they leave that situation, that's potentially the divorce or the abandonment category. And then the homelessness is yet a whole nother category of feeling unsafe and powerless. ACEs have a different impact on the brain based on the age of exposure, individual factors, and microsystem protective factors. There are youth who unfortunately end up at some point living with their caregiver in a car. And not all of them go on to develop long-standing physical and mental health issues because the caregiver there was a secure attachment. The caregiver was able to focus on the child. The caregiver was meeting that child's needs, and the child continued to feel, to the best extent possible, safe and loved. Strongest impacts are found for children under the ages of 5 and those living in households with incomes below 200% of the poverty line. Younger children, ages 2 to 5, need a lot more than 5 plus. They need their diapers changed. They need more structure. They need more stuff. And 2 to 5, in a lot of cases, they're not in school yet. So they're not interacting with other children, with other grown-ups, with other environments. They're in their household pretty much all the time, whatever that household looks like. And those that are in 200% or below of the poverty line, there's chronic stress. Most people that are living in abject poverty experience a lot of anxiety, a lot of distress, which alters their sleeping habits and their circadian rhythms and makes them more impatient and alters their ability to respond to other adults, let alone the children. And it makes sense. We also see addiction in people who are living in poverty. Now, addiction cuts across all socioeconomic classes, but we do tend to see more addiction in the people who are experiencing extreme distress. People who've experienced ACEs have a 200 to 400% increased risk of heart disease, cancer, chronic lung disease, skeletal fractures, mental illness, diabetes, insulin resistance, and liver disease. Why? Well, because of all the physiological changes we've talked about. When we have chronic stress, inflammation goes up. I'm not going to go through all the different steps. Chronic stress increases inflammation. When inflammation increases, our gut microbiome changes, which keeps the stress response going. It reduces the absorption of certain nutrients, hence the skeletal fractures. For some people, it changes their appetite. It alters hormones and neurotransmitters. And it also increases gut permeability. So some of those toxins from the gut get up into the system. The blood-brain barrier becomes more permeable, and toxins get into the brain, and we see more neurotoxicity, which also contribute to a lot of these things. A wide range of physical disorders, including obesity, dysregulation of the immune system, autoimmune diseases, and abnormal pain perception with and without underlying causes can also be seen. Stress itself, interestingly, when we have chronic stress, cortisol is a steroid and it's a glucocorticoid, but one of its main jobs is to help temporarily suppress inflammation. When the tissues are exposed to too much cortisol for too long, they become tolerant to it. They become resistant to it. And cortisol loses its ability to suppress inflammation. At the same time, our pain receptors become more sensitive, which is kind of a cruel joke that our body plays on us. But we do see increased pain, increased physiological responses to pain in people who are chronically stressed. And we recognize that chronic pain is a risk factor for anxiety, depression, irritability, and addiction. Therefore, helping people develop tools to manage their pain, non-pharmacological tools to manage their pain, to manage their stress, can be really helpful. Helping them identify triggers for their stress and start recognizing the connection between their stress in any of the pieces of their life and their pain threshold. Days your pain's better. Did you sleep better? Did you have less stress? Help them start seeing that connection, because that can help them help motivate them to engage in some of the cognitive behavioral tools that hopefully they will be learning in counseling. Specific physiological impacts of ACEs, sleep disturbances. If you don't feel safe, or if you feel like you're going to be abandoned, if you feel like you're going to be abused, if you're neglected, you're not getting food in your tummy, or you don't have, it's 2 a.m. and your caregivers aren't anywhere to be found, you're probably not sleeping very well. So sleep disturbances are very common in people with ACEs. Hypervigilance. When we become stressed, our brain naturally says, I feel like there's a threat. Therefore, I need to be on high alert for any of the threats. Think about a soldier in a foxhole. It's the best analogy I can make. Sympathetic dominance. When we're stressed for too long, our stress response system becomes imbalanced. The part of our stress response that reacts to stressors becomes more powerful, more hair trigger. The part of our nervous system that helps us calm down, helps us downregulate our parasympathetic nervous system, it becomes weaker. It loses its ability. The vagus nerve loses what they call vagal tone. And we can help our clients develop or improve their vagal tone through simple exercises, helping them. They can get and I don't have it here with me, they can get one of those pulse ox monitors that you put on your finger. Have them go walk around the outside of the building a couple of times, or, whatever they do, get their heart rate up just a little bit. We're not talking about jogging. Just get their heart rate up a little bit. Then pop that little thing on their finger, have them slow their breathing to try to watch their heart rate come down. There's no somatic scanning, no body scanning, none of that may trigger trauma. They are looking at a number, and that helps the body learn to downregulate. When they sit down after they've been walking, their heart rate's going to slow. If they intentionally slow their breathing even more than it just would naturally, their heart rate's going to come down faster. It's actually a very empowering technique. Have them keep that pulse ox monitor. They can get them for like $5 online. And when they start feeling distressed, anxious, irritable, encourage them to put that on and slow their breathing. Breathe in for 4, hold for 4, exhale for 4. All they're doing is counting and watching that number. They're not focusing internally. Now, you can do some somatic focus if your client is able to and it doesn't trigger dissociation or flashbacks or anything like that. However, focusing on that pulse ox, or if they've got a fitness tracker. Now, I will tell you, and I tell my clients too, the fitness tracker tends to be laggy. Mine's about 30 seconds behind. So my heart rate will slow down and it'll be about 30 seconds before that actually shows up on my heart rate monitor, on my fitness tracker. You can also have them get a H10 band from Polar. Again, you can get them online. They're a little more expensive, but those are the gold standard. And those are really sort of second to second accurate based on what's actually going on with your heart rate. They're a pain in the butt because you got to put them on and they're not comfortable to wear around all day, which is why I like the Pulse Ox. It's $5. They can carry it in their purse. They can plop it on their finger. If they, get jammed up in traffic and start getting stressed, they can put it on their finger when they're not moving the car. But helping them start connecting the dots, recognizing when I start getting stressed, I do have the ability to turn on that parasympathetic nervous system. As the parasympathetic nervous system turns on, those executive functions come back online. And it's a whole lot easier for them to evaluate the facts in this context at this time to determine whether they are safe. Changes in the gut microbiome and leaky gut. That happens when we're stressed. It's just what happens. Therefore, stress management is really important. Additionally, eating a healthy, non-inflammatory diet is very important. Encourage them to consider having 3 colors on their plate at every meal. That helps them get the antioxidants and the fiber that can help feed some of those microbes. When the microbes get the fiber, they turn them into short-chain fatty acids, which kind of powers the whole system. Those are all helpful. Nutritional changes. When we're stressed, we typically eat differently. We typically gravitate towards high energy, dense foods, high sugar, high fat, high processed foods, which is inflammatory in most cases. We tend to gravitate away from those healthy foods like apples. Encouraging people to be mindful of what they're eating. That doesn't mean cutting out everything they love. That's not fair, and they're not going to stick to it. But encouraging them to be cognizant of what they're eating and why they're eating is important. Absorption changes. When our gut microbiome changes and when our gut becomes leaky and inflamed, we don't absorb nutrients as well. Even if they're eating a healthy diet, they may not be actually getting all of the nutrients that they're ingesting. It's just passing through them. And the way we utilize stuff changes. Because that gut microbiome changes, it may use the byproducts of the foods that you eat to make different neurochemicals and different hormones than it would if the other group of microbes was on duty. Increasing awareness of how nutrition and what we eat helps people feel is important. Now, of the changes that people make, that's usually one of the last ones they're willing to do. But okay, and do it gradually. Start by adding 1 color to their plate at every meal, and maybe decreasing caffeine after noon. Those are 2 huge changes that can make a huge difference. Increased systemic inflammation. When we're stressed, because that cortisol eventually loses its ability to do its job, we have increased systemic inflammation, which leads to increased neuroinflammation. And all of that triggers the stress response, causes brain fog, causes hormone and neurotransmitter imbalances, and increases pain. Inflammation in the long term is just not good. It's not fun. Short-term inflammation, like when you break your arm, it has its place, but we don't want it all the time. And as I mentioned, that systemic inflammation goes up to the brain because the blood-brain barrier becomes more permeable when we're more stressed. And that leads to activation of the immune cells in the brain, which increases neuroinflammation, which starts causing cell death. We start seeing shrinkage in the hippocampus and other parts of the brain. The great news, even if somebody is 60, they're way past that 25-year-old place where your brain solidifies, I guess. Neurogenesis is possible throughout the lifetime. What is necessary for neurogenesis? What is necessary for our brain to heal itself? Reduce stress and inflammation. Stress is very amorphous. You can have physical stress, interpersonal stress, emotional stress, cognitive stress, and environmental stress. Our job as clinicians is to help people identify where they've got stress in their life, mitigate the stress that can't be eliminated, and eliminate the unnecessary stressors to allow their brain and their body to rebalance and not be constantly in this excitatory neurochemical toxin-laden soup. Inter- and intrapersonal impacts of adverse childhood experiences starts out with lack of secure attachment. Now, remember I said people can have adverse childhood experiences and not develop traumatic injury because of the characteristics of their environment and their caregivers. But people who develop traumatic injury as a result of ACEs, which is unfortunately is most of them, often lacked a secure attachment to a caregiver. When we have secure attachment, when we have a caregiver that is consistently mindful of us, they kind of know where we are, they're kind of aware of whether we're happy or we're sad, they're not just completely checked out. That teaches us how to be mindful of ourselves. I remember when my son was little, I was mindful of him, and I would notice when he would start to get a little bit overstimulated. He had ADHD and is somewhat neuroatypical from being a micropreemie. And I would notice he was starting to become what we call disorganized. And I would say, son, I think you're kind of overstimulated right now. Why don't you go take a break? We didn't call it a timeout. He wasn't being punished. He would go into his room, and we had one wall that was completely white, and he would just go sit on his bed, and he could do whatever he wanted, but generally he would just suck on his pacifier and stare at the wall. And there was one day he was about almost 2, and I was working on the computer, and he came up to me and he said, "Mommy, I'm feeling overstimulated." Popped his pacifier in his mouth and all by himself toddled into the room. He had learned how to be mindful, be self-aware of what was going on. Attentiveness. So that's consistency. Attentiveness is spending time with the child because you enjoy it. You want to spend time with them. That teaches them self-esteem. It's like, hey, people want to spend time with me. They're not just here to yell at me. Responsiveness is when the caregiver recognizes how the child feels or what the child needs and responds and or helps them respond. So the caregiver, if the kid's having a good day and comes in and is all excited, the caregiver responds with joy, responds with however they're going to respond. If the kid comes in and they are completely distraught, the caregiver also responds. So it's not just reacting to the distress, but it's responding to the child and their range of emotions. If the child comes in and they're distressed, the caregiver is going to acknowledge, I can see that you're really angry or sad or however the kid's feeling. They're going to help the child downregulate because we're not going to get anything out of them until they can tell us what happened. We're going to help them explore what happened and different ways to respond. And we're going to help them choose a response and act to address the situation. So that mnemonic is idea. Identify the feeling, downregulate, explore what happened and what you can do about it, and address it. Children who are have a secure attachment with their caregiver, that caregiver is also encouraging. That caregiver says, you can do this. You want to try out for football? Score. Let's try it. You may make it, you may not, but I'm behind you. I'm going to be your best cheerleader. And if you fail, you've got a safe home base. And that's the S, is safety. You can come back. I'm going to love you just the same, whether you make the football team or not. I'm going to love you just the same, whether you get an A in this class or not. That's what secure attachment is about, creating an environment where the child feels noticed, supported, and encouraged to grow and loved for who they are, not necessarily what they do. But what disrupts secure attachment, or what happens when we don't have secure attachment? Lack of self and or other awareness. If they don't learn to be consistent, if they don't learn to turn off autopilot and check in with themselves, they're going to have a hard time addressing their feelings. If they don't feel like anybody wants to spend time with them, if they feel like they were a bother or nobody ever noticed them, then they're going to have low self-esteem, or maybe they were always criticized. They may have poor boundaries because responsiveness, the caregiver helping the child and being responsive, is going to help the child learn to set boundaries. And the caregiver may say, I can see you're really angry about this. I'm not angry about it. You're angry about it. So we have this boundary. You have the right to your feelings, and I have the right to mine. I'm not going to tell you how to feel. I'm not going to tell you you should let it go. I'm not going to tell you you should do this. I'm going to respect your feelings. So responsiveness teaches boundary setting and communication skills. Encouragement and safety help the child learn how to deal with their inner critic so it doesn't become toxic. Otherwise, they internalize what they fear other people are thinking, or sometimes what other people have said that has just been horrible. A lot of children who have low levels of encouragement have low efficacy. They don't believe they can do anything, so they don't want to try, and they have a very low frustration tolerance. They may have difficulty trusting others, expecting abuse, neglect, or abandonment because they never felt safe in their relationships. And in some cases, when there's not a secure attachment, the child may develop codependency, where they feel like they need to become indispensable to somebody in order to avoid being abandoned. Ultimately, adverse childhood experiences can lead to a child feeling scared and disempowered, and this gets internalized. And the inner child are memories as a child, and we can remember when we were a child how we felt when something happened. We carry those memories with us, and if we don't learn how to respond to them, if that inner child, all those memories we have is of feeling unsafe, then there's going to be a part of us that always feels unsafe. Low emotional quotient, and we talked about this a little bit earlier. People who don't grow up in a stable household often don't have a caregiver that teaches them how to identify feelings, how to identify what triggers their feelings, how to downregulate, and how to manage, how to identify what are my options for dealing with this to be the person I want to be and live the life I want to live. We see increased dysregulation because chronic stress, not feeling safe, creates that imbalance, creates that sympathetic dominance, and the child will more easily dysregulate. They'll more easily go from being okay to throwing a full-out tantrum. Helping the child learn how to downregulate can be helpful. And my handy-dandy bubbles, you can get these at any store. Those are great, or you can even have balloons that you keep in your pocket or your purse or whatever for the child to blow on. Anything that slows their breathing. There are also disturbances in cognitive and emotional processing, including reduced sensory gating and heightened attention toward threatening stimuli. When we're feeling threatened, when we're in fight or flight, our brain actually opens up and becomes more aware of everything. So instead of filtering out a lot of the extraneous stimuli, it notices everything, which contributes to attentional difficulties. There's an increased experience of loneliness, increased HPA axis or stress dysregulation, and reduced impulse control. When the child is chronically in stress zone, then that prefrontal cortex, the wise mind, executive functioning, whatever you want to call it, that's offline. When we're operating out of emotion, we tend to operate more impulsively, which obviously is a problem. And helping caregivers help children learn to recognize when they're feeling stressed and how to downregulate and think before acting is huge. Functional alterations in key stress and emotion-associated brain regions, particularly the amygdala, fear processing, and hippocampus, memory processing, can cause other problems in emotional and cognitive processing. The amygdala and hippocampus are particularly susceptible to damage from trauma and chronic stress due to the high density of glucocorticoid receptors. So there's a lot more hot neurochemicals, if you will, flowing into those areas of the brain, which makes it easier for those neurons to get fried. Exposure to ACEs selectively affect the sensory systems which were involved in perceiving the trauma. Smells, sights, sounds, whatever senses were engaged during the trauma or experience of ongoing trauma are going to be heightened. Mental disorders in individuals with ACE exposure tend to have more severe symptomatology, increased risk of comorbidity, and are less likely to respond to standard treatments. Why? My hypothesis is that standard treatments involve talk therapy, yet do nothing or virtually nothing to help the person re-regulate their nervous system and reduce systemic inflammation so their brain can heal. Environmental aspects of ACEs include difficulty maintaining a job due to all the other impacts that we've talked about: emotional dysregulation, brain fog, impulsivity, pessimism, all difficulty with executive functioning, difficulty to maintain a job when all those things are offline. Transportation difficulties due to lack of an automobile or a driver's license, because you lose your job, you can't pay the car payment, you lose the car, or if you develop an addiction, you get a DUI, you lose your driver's license. And a lot of places don't have buses. Unstable housing due to lack of stable income and or relationships, and lack of safety due to an abundance of triggers. Everywhere, and I know that's an extreme word, the person looks, there's a trigger, a smell, a sight, a sound, a person, something that can potentially cause them to feel unsafe. We need to help them identify what triggers are, because we can't possibly plan for every trigger, but identify what triggers are, help them understand that that's a sensory input that's causing their brain to remember past situations where they were unsafe, and use the facts in this context at this time to determine whether they are objectively unsafe in the present. Spiritual impacts of adverse childhood experiences. Impulsivity is more prominent than prudence, acting with purpose. People who've experienced ACEs often give up easier because they're like, what's the point? It's just another day in this crap show. The child or person may develop the idea that nobody can be trusted, not even themselves, so they don't have respect for themselves or others. They may be filled with resentment and guilt and have difficulty loving and trusting because they can't forgive. They may do the minimum because they don't see the point of, really giving 110% because it doesn't ever seem to work out. They may have difficulty having compassion for self and others because all they've experienced most of their life is judgment. And when they don't have compassion for themselves or others, it's really difficult to connect with and trust other people. If I'm constantly judging myself or judging you, I'm going to have difficulty trusting and connecting with you. It's difficult for them to be truthful with themselves and others because they often learned that the only safe thing to do was either be very passive, so everybody was doing whatever and they had no say in it. They had their boundaries just completely obliterated, or they were a chameleon to survive and they weren't able to thrive. They just did whatever the other person wanted them to do because that was the safest thing. And selflessness to the extent that it doesn't cause self-harm. And this is where we see a lot of codependency. A lot of people who experienced ACEs are selfless to the degree of being enabling and to the degree that it causes self-harm. They give and give and give because they so want to be loved and don't feel worthy of love or fear abandonment. What do we need to do? In the assessment, evaluate people who've had ACEs through a trauma-informed lens, recognizing the reciprocal impact of trauma on every piece of life. Physically, the nervous system, circadian rhythms, inflammation and autoimmune conditions, hypervigilance, diabetes and blood sugar issues, chronic illness, pain, and reduced sensory gating. Interpersonally, look at self-esteem, relationship skills, attachment style. Emotionally, evaluate dysregulation, their emotional quotient or EQ, and any mood disorders. Cognitively, we want to evaluate their schema based on their experiences through a trauma-informed lens, difficulty learning new things or changing perceptions due to constantly being stressed, even in therapy. Attention deficits and impaired executive functioning. Sessions may need to be shorter for a little while. And environmentally, they may have difficulty just feeling safe in the room, in their own skin. They may have job instability, housing instability, and sensory hypersensitivity. We want to look at referrals and wraparound services to help them get those basic Maslowian needs met. Treatment begins with creating safety and a sense of hope and empowerment. Recovery is possible, and your experience is real. Those are the takeaway messages. We want to help them address current trauma symptoms in each piece of life, including physically, helping them balance their circadian rhythms and improve their sleep hygiene, learn more about proper nutrition, pain management, and enhancing their vagal tone. Interpersonally, addressing negative, in particular, self-referential thoughts, esteem, and efficacy. We want to look at helping them learn how to set boundaries and guilt that they may have about imposing or maintaining boundaries, or their fear of lowering excessively high, strict boundaries. We want to help them learn assertive communication and how to listen without defensiveness. We want to educate them about the neurological basis of dysregulation and how to downregulate. We want to help them develop an improved emotional quotient so they're more effective at identifying their emotions, down-regulating, exploring, and acting. We want to help them learn about behavioral activation, that is, doing things that actually make them feel positive, maybe not happy. Help them identify and restructure schema that have been based on traumatic experiences and traumatic expectations of the future. Help them develop supportive interventions for executive functioning. Write it down. Don't force yourself to overtax your brain right now. And address cognitive distortions, especially personalization, minimization of the positive, maximizing the negative, emotional reasoning, jumping to conclusions, the availability heuristic, that is thinking that something is based on what pops into your mind immediately, not necessarily based on the facts, and all or nothing thinking. And we can use the mnemonic FEEL here. Facts, what are the facts in this context? Exceptions, what are the exceptions to this being all or nothing? Explanations, what are alternate explanations besides it's all me or the worst case? And what is the likelihood that my worst fear is actually going to come true? Environmentally, help them identify and enhance positive triggers that help them feel safe and empowered. Help them identify and minimize trauma triggers. Help them address sensory over or under stimulation. Seek out vocational counseling, housing support, and, if needed, transportation interventions. ACEs fundamentally alter a child's sense of safety, personal power, and lovability. These changes trigger the stress response, which leads to a variety of changes in all pieces of life, partly as a result of the downstream effects of chronic inflammation. Assessing for ACEs and whether or not the adult and the inner child feel safe and empowered is essential to understanding 80% of the iceberg that's under the water. What they're presenting with is the 20% that's above the water. Treating people with ACEs requires untangling the web of the biopsychosocial impacts of trauma that are keeping them stuck.